Hello, my name is Martin Hoenigl. I have a double appointment at the Division of Infectious Diseases and Global Public Health at UCSD and the Section of Infectious Diseases of the Medical University of Graz, Austria, and I will talk today about point-of-care diagnosis for invasive aspergillosis. My disclosures. So we know for invasive aspergillosis, early diagnosis is difficult. Culture has generally a low sensitivity, in particular during early stages of infection, and galactomannan testing has really become the imperfect gold standard. But it also has, of course, not less than perfect sensitivity and specificity, specifically in non-neutropenic patients. And turnaround time varies. And when we think about a global perspective, it's really striking that even galactomannan testing is not available in the vast majority of settings around the world. As shown here in this publication from 2018 from Asia, where out of 241 laboratories, only 23% indicated that they performed galactomannan testing on site. So we need better diagnostics and potentially also more rapid diagnostics. And that's why there was great enthusiasm when this first point-of-care lateral flow device test for invasive aspergillosis came basically to the market. So it's a point-of-care test that's relatively specific for invasive aspergillosis. It detects an extracellular glycoprotein secreted only during active growth of Aspergillus via this monoclonal antibody JF5. And it's a simply rapid, single-use, pregnancy-like test, as you can see on the picture, that can be performed in rudimentary facilities using BAL or Serum specimens. And it's an English point-of-care test, the LFT. What we have looked into, so it took a couple of years really to develop this test. And there was always prototypes kind of like that were evaluated for the first 6 or 7 years. But then finally in 2018, a CE-marked version came on the market. And when we compared the CE-marked version to the prototype test, we found that the new CE-marked version had basically equal sensitivity but slightly higher specificity. And this was when testing the same samples that we had tested before with the prototype test. But how do the data look basically for those two tests? So below here we see this data published for the Aspergillus-specific LFT prototype. And we see an overall sensitivity and specificity of 71% and 92%, so relatively specific. Sensitivity 71%. And when we look down, a breakdown through the different patient groups, we see maybe a tendency towards slightly lower sensitivity in hematologic malignancy patients, which could hint towards an impact potentially of antifungal prophylaxis. But overall, I would say relatively consistent data for the old LFT prototype. And then moving on to the new CE-marked Aspergillus-specific LFT, we see generally that sensitivity is a little bit lower, really in contrast to what we found when directly comparing these two tests, and specificity all again close to 90%. And this is of course maybe driven due to the fact that the results may differ between studies and may not be comparable between different labs due to the visual readout, which can be kind of like sometimes tricky, especially at the slightly positive test lines. What we see here so far published for the new CE-marked Aspergillus-specific over LFT test, that, again, most patients were evaluated with underlying hematologic malignancies, where there was 70% sensitivity and specificity. And really, there was mainly one study that really resulted in kind of like lowering the sensitivity, which was done in solid organ transplantation patients where low sensitivity was found. But again, this was done with visual readout and may not be kind of like, the same at every center. And intensive care unit patients here, again, 64% sensitivity. So how about the LFT test from blood? Significantly fewer studies have been done from blood for this test. But what was found basically is that the overall sensitivity was very low. So 20% sensitivity, highly specific with 90%, but with this low sensitivity, of course, it's a question basically how much you can use this test. Of course, we need more studies. So this is only based on 2 studies that have been conducted. And we know from the old prototype that there were more studies conducted basically that found also a higher sensitivity and specificity. So I don't think it's the last word about performance, but we definitely need more data before we can perform reliably the LFT test from blood. And we know, of course, that also galactomannan from blood for single samples is not performing really well. It's only the screening and multiple testing that makes the test valuable. So, and that was, not evaluated for the LFT so far. So what about the second point of care test, the Aspergillus galactomannan LFA test, which really, came to our attention as a potentially a more sensitive point of care test. So you can see here, it looks a little bit different. It looks a little bit more like a test that's performed in a lab versus really point of care next to the patient. It's produced in the US, basically by Immunodiagnostics from Oklahoma in the US. Results are read after 30 minutes and scores given in the range between 0 to 4. And FDA approval is expected for this test. This test has been CE marked from the beginning, and now it's about to get FDA approved. I think the one downside to the test is, of course, that it's not really point of care, so you can't test a BAL natively directly on the bedside, which is possible in some circumstances with the other LFT test. But nevertheless, when we look into performance, and I'll show you this over the next slides, you can see that kind of like, overall this LFA is really promising. So here we have a summary of data published to date for the manual readout. So this is really a manual readout, and we see overall a sensitivity of 77% and a specificity of 81%. With the manual readout, and you can see here, good amount of samples, 110 samples evaluated for sensitivity and 181 cases for specificity. This is all from BL fluid. When comparing the subgroups, again, a little bit a similar picture that we've seen with the LFT. Better performance in patients with hematologic malignancies, despite frequent use of antifungal prophylaxis, and less good performance in SOT patient and intensive care unit patients. Overall, the sensitivity in all these studies was similar to BL galactomannan, but higher compared to Aspergillus, the LFT, and BL culture. And what are the reasons that this test is not performing as good in solid organ transplantation patients and intensive care unit patients? Mainly, it's probably the fact that we don't have that reliable definition, those reliable definitions that we have for hematologic malignancy patients in these settings. So it really seems that aspergillosis is having a different clinical picture in non-neutropenic patients, in patients with corticosteroids, that may not be as reliably captured by the current definitions that are available. And it's really a work in progress currently to really create better definitions specifically for ICU for non-neutropenic patients at risk for invasive aspergillosis. Also one study done of the LFA by the chair of the current session, published in CMI 2019, which looked into Aspergillus culture positive samples and found really a sensitivity and specificity that was very high of 92% and 91%. So once you go down basically to this, 23% or 25% of cases of aspergillosis that have a positive culture from BL, you have even higher sensitivity and specificity with the LFA. What about testing the LFA in serum? Again, you can see, limited data currently available. 2 studies published this year from Louis White and Tuan Mercier, that really found also kind of like very promising and, comparable to serum galactomannan results in serum with sensitivity of 70% and specificity of 96%. All of these studies done, or both of these studies done in patients with underlying hematological malignancies. Nevertheless, this didn't look bad for the LFA, but nevertheless, of course, it's a constant thing. One of the problems with these point of care tests, and you can see it here in a picture from our lab, basically, is that once these lines become very thin, it may be hard to read as a positive versus, slightly positive versus a negative test, which makes a big difference. So what recently really was introduced, and is really the current trend, is to have a kind of like an objective readout with a reader, an automatic reader of the test line intensity, which really measures the optical density index, similar to galactomannan, and handheld reader, cube reader is now included in this LFA kits. So what was shown for this reader is really in this big study from Merci from Leuven in Belgium, with a good amount of samples and cases with underlying hematologic malignancies, that even though the sensitivity and specificity was already pretty good with visual readout by 2 investigators, a digital readout resulted in an increase of sensitivity and specificity. The end sensitivity and specificity all around 90%. Also in this study, sensitivity was higher compared to the LFD, and basically also the area under the curve for the digital readout was a little bit higher for the LFA than for the LFD, although also the LFD had a better performance with the digital readout versus the visual readout. So we have also performed a study on the BL lateral flow assay for invasive aspergillosis, a multi-center study that has recently been accepted in clinical infectious diseases, and looked into BL fluid samples from San Diego, Graz, and Mannheim, 88 samples from patients with probable proven or putative IPA mixed cohort, and 161 without. And we used the cube reader. And what you can see here on first visual inspection, this in blue is the BL fluid LFA of optical density indexes, and in red is the BL fluid galactomannan optical density indexes. And you can see that this is really much going in line with much higher levels in density indexes in putative, probable, and proven cases versus possible or no cases. And here you also see we also found a significant correlation between the LFA and the galactomannan from BL fluid in our study. And once we excluded galactomannan as mycological criterion for case classification, we really found the diagnostic performance of the LFA was highly similar to galactomannan testing, with an area on the curve of 0.892 versus 0.893. So really similar performance. So once this advantage of galactomannan that it is defining the disease is removed, they are really completely similar in performance from BL fluid. What we also found here is basically that there was a pretty much consistent performance of the BL fluid LFA in different patients cohort. So overall we had an area under the curve of 0.865 for probable putative or proven IPA versus no IPA. And in hematologic malignancies it was 0.917, again the highest, a little bit lower in solid organ transplant recipients with 0.806. and intensive care unit in the middle with 0.867, but really in all 3 patient groups a reliable test. What was also even more striking was that the performance was really the same in all 3 different study sites, and the test was really performed on site in these 3 different centers. But you can see that these errors under the curve at UCSD, in Graz, and also in Mannheim really were highly similar between 0.844 and 0.866. So really kind of like, it shows that this is now objective readout, and the test performances are really comparable between centers. In terms of cutoff, when using this cube reader, I think this is still a thing that has to be determined. Basically, what we found is with this 0.5 ODI cutoff, it's really kind of like not very specific, whereas a 1.0 ODI cutoff at least seems to be preferable with an overall sensitivity and specificity of 82% and 73%, versus, of course, specificity increases further to nearly 90% once you use a 2.0 ODI cutoff. Very quickly, just over the slides, I think, over the last few slides, I think, I pointed out that I think that LFA is a very valuable test for diagnosing aspergillosis, but it may also be valuable in combination with other established tests like Aspergillus PCR, galactomannan testing, BL culture, and others, specifically for diagnosing breakthrough infections, because we know that all the tests, galactomannan, also the LFD, have significantly reduced sensitivity in patients who are on mold-active antifungals. So significantly reduced sensitivity for breakthrough infections, and the same is true for PCR. So we have done a recent review where we kind of like, looked into PCR performance by proportion of patients with anti-mold prophylaxis, and it's really striking how much this performance correlated. And of course, we know the same is true for culture. So also here, these point-of-care tests may have a valuable role as a test that can be used in combination for diagnosis of breakthrough infection. And with that, I come to the conclusions. Point-of-care tests for diagnostic tests for invasive pulmonary aspergillosis are now commercially available, and 2 tests are CE-marked, and 1 soon FDA approved, which is the LFA, and the LFD is also available in many parts of the world. These tests have been shown to reliably diagnose IPA, and performance can be further improved by automatic readout of the test results, and both the LFA and LFD have potential to diagnose invasive pulmonary aspergillosis alone, but can also complement galactomannan culture as well as other biomarkers for optimizing diagnostic performance for IPA, specifically in the breakthrough setting. With that, I want to thank you for your attention.